So, hello, I am Dr. Janelle Jackman. I am a board certified OBGYN and minimally invasive reproductive surgeon here at Kindbody. I work in Los Altos and I, really love educating, and I'm happy for everyone to be here today to learn a little bit more on fertility and the Black experience. I'll hand it over to my colleague, Dr. Tonya Wood.
Hi, good afternoon and good evening to everyone. My name is Tonya Wood. I'm a psychologist with Kindbody and come into this space as a provider, but also as someone with lived experience. So providing information and support, especially to women of color, especially to Black women, is extremely important to me. So it's just really a pleasure and a privilege to be with you this evening. Deja?
Hello, everyone. Welcome. I'm Deja Riley, based in New York. I am a wife, a daughter, a sister, a friend, amongst many other things, a Lululemon Studio trainer and ambassador, and very proud to say I am a Kindbody patient. I'm looking forward to sharing my story with you this evening. And I hope that you all came prepared to take some notes because we've got some great information for you tonight. I'm going to toss it back to Dr. Janelle Jackman.
So here at Kindbody, we're on a mission to make reproductive health and fertility care accessible to all. We serve our patients directly and also through employers as fertility and family building benefit. So we want everyone to feel welcome, despite your creed, your race, religion, doesn't matter. We welcome everyone at Kindbody, and we hope that you get a lot out of this presentation today. So what we do basically can be separated into fertility. We actually do a little bit of GYN as well as counseling and support. So under fertility at Kindbody, you can get fertility consultations for both men and women, virtual consultations with board certified physicians, as well as fertility specialists. Some of the treatment options we do entail egg and sperm freezing, embryo freezing, intrauterine insemination, and in vitro fertilization. We also work with third-party reproduction that includes donor egg and sperm, as well as genetic testing and fertility testing. Under counseling and support, we have LGBTQ plus specialized support. We have donor and surrogacy programs. So if someone needs to use the donor egg, sperm, or embryo, or if someone needs, assistance carrying the pregnancy, so someone else is going to carry the pregnancy for you, we call it a gestational carrier, and we support, have all the support in Kindbody. So Kindbody is very proud to have in-house surrogacy agencies, and not many fertility clinics have that. We also specialize in wellness geared towards reproductive health, nutrition, focusing on fertility, polycystic ovarian syndrome, pregnancy and lactation needs. And last but not least, we also focus on mental health with Dr. Tonya Wood and some of her colleagues, where we focus on many different things in mental health, but particularly on recurrent pregnancy loss, infertility, the pregnancy and the postpartum aspects. So on today's agenda, we have clinical components and fertility 101. So basically, we're going to go through the clinical reasons that lead to an increased risk of infertility and fertility education. I'll be covering mainly that part. In part 2, Dr. Wood will take over with the socioeconomic barriers and how to overcome them. So basically, socioeconomic barriers to attaining equal reproductive health and fertility care. And then in part 3, we're going to have patient stories and advocating for yourself, where Deja Riley will tell us her journey and how basically to be your own best advocate as a patient at home and with your doctor. And she will share some of her experiences along the way. So where we are, as a group, persons of African descent experience disparities with many things, including healthcare. So we have with chronic conditions, access to care, preventative screenings, and mental health, with fertility and reproductive health being among these conditions. So we may encounter many defeats, but we must not be defeated. Maya Angelou said it well. So this is, part of what we want to empower you here today. Representation matters. This is a quote that I previously had, and it's still true. It is statistically proven that in healthcare, patients of color have better outcomes when we're treated by our doctor of color. And I'm personally both humble and proud to represent a small yet powerful number of Black female physicians. There's only 2% of us in the United States of America. Representation in healthcare goes far beyond comfort, but it can save lives and improve results, particularly for patients of color. There are many clinical disparities, as I said, in healthcare, but particularly in infertility. Many studies have shown that Black women are it's actually 2 to 3 times more likely to experience infertility compared to white women. And the fact is that when Black women does attain access to reproductive treatment, they experience lower success rates compared to their white counterparts, and they usually present much later on. That's where we want to try to bridge the gap. Clinical disparities in infertility lead to poor outcomes, and this is disproportionately higher in Black women seeking fertility care. We have lower implantation rates when we do embryo transfers. We have lower clinical pregnancy rates with fertility treatment, and we have an increased miscarriage rate. And the more we talk about it is the more that we empower people not just to seek care early or to have intervention, but just knowing that they're not alone, because a lot of it comes from not just socioeconomic, but also cultural aspects of the Black community. And knowing that, you're not alone, there are other people like you out there will make you feel more empowered to seek help. So Michelle Obama, our late, or previous, sorry, Barack Obama's wife. I don't even know why I have to explain who Michelle Obama is. We all know who Michelle Obama is. But anyway, she experienced infertility and she felt like she failed because she didn't know how common miscarriages were. People don't talk about it, right? So people tend to sit in our own pain, feeling broken. But the more, people talk about it, so we're very thankful to have Deja here today. The more we share our experiences with others, especially within our community, is the more that we know that we're not alone, there's help and there's intervention that we can take, which is why it's very important for everyone who's on the panel here today, to be on the panel here today, to sort of, give this perspective. So now I'm going to delve into the fertility 101. So this is like the medical aspects of things, okay? So they're basic building blocks in conception. And I always like to start off with the egg because I'm a woman, so I'm biased. So we need an egg, we need sperm, we need to have normal anatomy. And when we're speaking of anatomy, we're talking particularly of the fallopian tubes and the uterine cavity. I like to go a little beyond with patients to say that we also need fertilization to happen, which is the egg and the sperm must meet successfully and everything must be done in the right timing. So I give 5 building blocks, not 3, but basically these are the building blocks for fertility, okay? Egg, sperm, normal anatomy, fertilization, and timing. What we should know is that when it comes to fertility, though, the absolute most important thing to think about, particularly in the woman or patients assigned female at birth, is your age, because the egg is very influenced by our age. So we're going to start at the beginning. Anyone assigned female at birth out here today, just note, we are born with all the eggs we're ever going to have in life. It's about 2 million at birth. So I like to kind of describe the ovary like a bank, but you only get a one-time lifetime deposit at the beginning of life, and that's 2 million. By the time you reach your first period, so we call that, menarche, the first period ever for puberty, you're already down to about 350,000 eggs. So imagine that in about 12 to 13 years, you've lost more than half of this deposit, and you can't redeposit anything because it was the one lifetime deposit at birth, right? From there, we're just constantly losing eggs every month. About 1,000 eggs we lose every month. And we lose about 1,000 eggs regardless of if we are menstruating regularly, regardless if we have polycystic ovarian syndrome, regardless if we're on birth control, regardless if you're bleeding or not. We're losing 1,000 eggs every month. And this is important to know. And that's why in terms of the woman or the patient assigned female at birth, this is why we have that steady decline over time, because we're born with all our eggs, but we're also losing eggs constantly. And on top of that, our eggs are aging with us. So we have like a three hit against us, okay? So this is like a chart displaying our ovarian reserve. Ovarian reserve is how many eggs approximately we have left in the ovaries, right? And this is sort of standard for age with slight variances based on genetics and family history and race, but more or less the same throughout. As I mentioned before, like around puberty, you're at 350,000. So that's the peak of the graph. You see it around 13 years. And then it's steadily declining, as you can see, around 130,000 between 20 and 25 years old. At 30, you're down to about 70,000. At 37, I say you're down to about 25,000. And then at menopause, most people happen between 50, 52 years old. You're going to be about 500 to 1,000. But remember what menopause means. It means that you're no longer releasing that egg. So you're not ovulating, you're not releasing it. So your ability to get pregnant is, practically impossible using your own eggs when it's at menopause. So you can see that steady decline in our ovarian reserve, but also declining is the monthly birth rate. So our ability to get pregnant is also declining based on that decline, but it's declining because, as I said, as we get older, the egg is aging with us, right? So you can see that, in teenage years when most of us are trying to get pregnant, you're in your 20% chance of getting pregnant per month. But as we hit 30, this is closer to like between 15 to 18%. At 40, you're down to about 6%. And beyond that, it's very close to zero. It's not zero, but very close to zero. So our ovarian reserve is declining with age, and our ability to get pregnant monthly is declining by age. So there is always this critical number, 35 years old. Some of us may have heard 35 already. It's, called the advanced maternal age or geriatric. I hate the geriatric term, actually. So let's stick with advanced maternal age. So at 35, we will typically point to the fact that this is the age where fertility declines. But your fertility is not an off and on switch. It doesn't mean, okay, 35 comes and it just turns off, or before 35, it hasn't started. Realistically, your decline in fertility actually begins at 32. There's a small dip in it. It's not as drastic as at 35, which is why most of us focus at 35. But your fertility is actually constantly declining over time. Some people, the decline will happen, a little after 35, some people before. But the point is that this is the age where you have to think about this age more or less. The age of 35. And 1 out of 10 women are going to experience premature low ovarian reserve under the age of 35. So it does not mean that because you are younger, it automatically means that you have the expected ovarian reserve. Likewise, not because you're having monthly periods mean that you have the expected ovarian reserve. So these are like common things that we think, or we tell ourselves that, I menstruate every month and I'm less than 35, so I'm safe, and it's not actually true, okay? Okay, so both quality and quantity matters when it comes to egg, and as I said, both are reduced with age. So as we get older, both quality and the quantity of our eggs decline. Poor egg quality can result in an increased risk of miscarriage due to a chromosomal genetic abnormality. It can also result in an increased risk of just not getting pregnant altogether. So therefore, age does matter when we're looking at the eggs. The reality is you're never too young or too old to learn more about your fertility and how it works and where things stand. So a lot of patients, you have to be more proactive and, start looking into these numbers, start looking at your fertility number. Well, I don't like to call it fertility numbers. These numbers actually will not tell us whether or not you can get pregnant. So I like to clear that misconception up as well. But it will tell us that if in the future, or if currently you need assistance in fertility treatment, it tells us how you're going to respond to treatment. And it may give us an indication of certain conditions if we see much higher than expected numbers or much lower than expected numbers. So when are we most fertile? Some people think that to get pregnant, you have to have sex throughout the month, and that's actually not true. It will get you exhausted, and you probably will not like be fed up by the time you're trying. So we have something called the fertile window, which is the best couple of days to get pregnant. If you have a regular cycle, most fertile days are between 10 to 14 days of your cycle, with day one being the first day of your period. Now, there are ways to track this using ovulation prediction kits. So basically, for about 5 to 6 days, you're going to be the most fertile you're ever going to be. And it starts with, if you use your ovulation prediction kit to see when your LH rises, you can calculate this period. So we predict when you're going to ovulate, and the best time to have sex will be 5 days prior to ovulation. And this is because sperm can last 3 to 5 days. So we want you to have the sperm on board before you ovulate, before you release the egg, because the egg only lasts less than 24 hours. So we rather the sperm wait, men should wait anyway. So we rather the sperm wait for the egg than vice versa, because the egg may not still be there, okay? So there are different ways that we evaluate someone when they're trying to get pregnant, or for that to evaluate an ovarian reserve. So many patients will come and they want to know, like, what is my ovarian reserve? And it's a number that tells me how many eggs you're releasing every month, as well as how many eggs you have left approximately. So there are two ways to do this. We look at an ultrasound. So we do a transvaginal ultrasound, meaning an ultrasound within the vagina, and we look at the ovaries, both left and right, and we count how many follicles are on each ovary. Now, follicle we use sort of interchangeably to represent an egg, even though it's really not. The follicle, think of it more like the egg container. And we can't see an egg, it's too small. So we see the follicles that start to grow on the ultrasound, and we count the ones on the right, add them to the ones to the left, and that gives us a follicular antral follicle count, or AFC. And this is one way we kind of determine what your ovarian reserve is. What we see on the ultrasound is what your ovary is releasing this month. Another test that we currently do is blood work. And the particular hormone that we look for is your anti-Mullerian hormone, or AMH. AMH is a number that tells me how many follicles or eggs you have left in the ovary. This hormone would range from 1 to 6 being normal, typically less than 1 being low value. So if your number is between 1 to 6, typically you have, a normal number of eggs left in your ovaries. So the testing will also tell you more about the quantity of your eggs. So AMH and your follicle count tells me about the number of eggs. So as I said, the AMH tells me how many eggs you have left. Your AFC, or antral follicle count, tells me how many eggs you're practically releasing for the month. And both numbers are quantity tests. But remember, fertility is more a quality test. So you also want to take quality into consideration. Quality declines with age. I think this next slide. Oh, sorry, go back to the first one, sorry. So quality declines with age, my bad. So quality declines with age. So when we look at quantity, which these objective tests can tell us, ultrasound and blood work, this is telling me quantity. But when I look at quality, how good the eggs are, I'm looking more at a patient's age, or if a patient has a significant drug or medical usage. So somebody who has chemotherapy, radiation therapy could have a decreased quality even if they're younger, because of obviously how toxic those drugs are. But in general, your quality is based on your age. Less than 35 years old, we expect 70 to 80% of your eggs to still be good quality. From 35 to 37, this number drops 40 to 60%. At the age of 40, we're looking at around 20 to 30%. And over 44, it's less than 1%. So you can see both our quantity as well as our quality are both declining with age. So the next factor we have to look into, because remember I said it's egg, sperm, anatomy, is that we have to evaluate the sperm. To evaluate the sperm, the man will just have to give semen for analysis. So they ejaculate into a cup and submit that specimen to be evaluated. Basically, we look at the volume of semen was produced. We wanted over 1.5 mil. We look at the count of sperm, how much sperm per milliliter produced. Then we look at the movement of the sperm. We call that motility. This is a percentage of all the sperm we see. We want at least 40% of the sperm moving. Lastly, we look at the morphology. This is the shape and the size of the sperm. And to be honest, we don't expect many sperm to have normal shape and size. So we just need as little as 4% of the overall sperm to be normal shape and size to expect the semen analysis to be good quality. There are other things like the thickness, the acidity, the content, the cloudiness, all these are other things, but the main factors are what listed: volume, count, motility, morphology. Last but not least is evaluating the anatomy, making sure the anatomy is normal. So there are basically 3 different ways we can evaluate anatomy. So we want to, when I say anatomy, we're talking about the uterine cavity as well as the tubes. So the first is that we can do a saline infusions ultrasound, in addition to saline air bubble study. So we kind of classify this as one thing called a saline bubble study in Kindbody. So we put an ultrasound in the vagina, we put a catheter in the uterus, and we put normal saline, and we look at the cavity expand, as you can see in these images, on the ultrasound. And then we put a little bit of air bubbles, and we look to see if we see air bubbles in the pelvis. It tells us that the tubes are open. So that's an ultrasound-based evaluation of the uterus and the tube. We can also do an HSG, or hysterosalpingogram, which is the picture that's kind of below the two. And this is where we put a catheter inside the uterus. We don't do this personally in Kindbody, but you can have this done at a radiology center. They put a catheter inside the uterus, they put contrast dye, and then they take a bunch of x-rays called fluoroscopy, which will show the dye filling the cavity. The cavity should look nice and smooth. And then you see the dye filling the tubes, and last but not least, spilling out. And the spilling out is important to tell us the tube is open. But in this test, we can also look at the caliber or the size of the tube to make sure that the tube is not dilated, because a dilated tube is also not great for fertility, okay? Last but not least is the hysteroscopy, sorry. There is also the hysteroscopy, which is a camera study. We put a camera inside of the uterus, and we can physically see the inside of the uterine cavity. This will not assess the tubes, however. So there are different factors. So hysteroscopy was the last one, but it doesn't evaluate the tube. So there are different factors that affect fertility, including our diet, health. We can go to the next slide, please. So yeah, that so our bodies basically function as a whole. So responding to our everyday routine and environment. So while some lifestyle factors may affect fertility, others may not. So for example, birth control doesn't seem to have any permanent effect on your fertility, but obviously while you're taking it, you're controlling birth, so you will not be pregnant. But different factors that affect is like our diet and lifestyle. So what we're eating, our exercise, what we're putting into our bodies. So that includes cigarette smoking and alcohol. These things all affect fertility. Our family history affects fertility as a lot as well. So patients who may have a family history of infertility or family history of different conditions, polycystic ovarian syndrome, fibroids, etc., and our mental health, okay? So our body functions as a whole. So that's why we treat you as a whole as well. And we try to make sure that the different factors are all working together to boost our fertility as well. Definition of infertility is basically the inability to get pregnant after 1 year of trying. However, if you're 35 years and older on this presentation, know that we will start workup after 6 months of trying. There's no use trying for more than 6 months. The chance of getting pregnant usually drops much lower. Doesn't mean that there aren't people out there who's getting pregnant beyond 6 months, but we usually recommend 12 months if you're less than 35, 35 and older, 6 months. About 1/8 of couples are going to experience infertility, and a third of that is going to be male factor causes. So kind of like the rule of threes, a third is male factor, a third is roughly female factor, and a third is a combined factor / a little bit of them being unknown cause. So this is how we, break down infertility. There are biological risks. So we're going to start off with some factors that are very predominant in Black women. So first, fibroids. Everyone on this talk, I'm almost sure, either know someone who has a fibroid, related to someone who has a fibroid, or may personally have a fibroid. And these are benign, non-cancerous growth of the smooth muscle in the uterine wall. It can grow above the uterus, on the external surface area of the uterus. It can grow within the muscle itself, or it could project into the cavity. And the ones that project into the cavity are the real ones that we're concerned about affecting fertility. It's unclear why Black women are at a greater risk for uterine fibroids, but we do see very much uterine fibroids present in a lot of Black women. Particularly, we present at later stages where the fibroids are very large, where it probably envelops the entire uterus. And this can have detrimental effects on reproductive outcomes, increased risk of miscarriages, preterm labor, or it may have failed implantation as well. It affects about 20 to 50% of reproductive age women, and it's disproportionately higher in Black women. Next is endometriosis, and I saw Yana ask a question on endometriosis. So endometriosis is the most common cause of pelvic pain, and it occurs in about 20 to 25% of women with infertility. It was a misconception that Black women do not suffer from endometriosis, but I'm here to say that that myth is debunked. Black women do suffer from endometriosis. There aren't many studies, but I can tell you I did an endometriosis fellowship, and it's very prevalent in Black women. So there is no like demographic that is spared from endometriosis. And what exactly is endometriosis? Endometriosis is basically similar tissue to the lining of the uterus. It's not the lining of the uterus, but it's very similar. Being found outside of the uterus, it may be found on the surface, it may be found on your bowel, your bladder, your ovary, within the ovary. It can be found anywhere, but once it's not in the lining and it's anywhere else, it's called endometriosis. And the problem with endometriosis is not only that it causes pelvic pain and severe painful heavy periods, but it can also cause infertility. It's actually very high in patients with infertility. So endometriosis is painful, but a lot of times patients who experience infertility, believe it or not, they may not experience the pain aspect of endometriosis. So I have seen personally that there are some patients with endometriosis that it's silent when it comes to active symptoms, but the symptom in itself is the infertility. So that's one thing I like people to know, that infertility is a symptom of endometriosis, even if you may not necessarily experience the painful aspect. And then polycystic ovarian syndrome, once again, very common, very prevalent. Polycystic ovarian syndrome is basically a condition where you do not ovulate as regularly as you should. So most people would ovulate once a month, somewhere between 21 to 35 days from the previous ovulation. But in polycystic ovarian syndrome, the ovulation is not as consistent, and people can go several months without ovulating with polycystic ovarian syndrome. This does lead to an increase in male hormones called androgens, and this can negatively impact fertility. So the androgens can impact fertility, but more importantly, if you do not ovulate, you're not releasing that egg, and hence it will impact your fertility. It is characterized by irregular periods. It is characterized by clinical or laboratory signs of excess male hormone production. And last but not least, you will see on ultrasound polycystic or multiple follicles on the ovaries. These are not typically what we characterize as cysts, as in abnormal cysts. Polycystic ovarian syndrome really should be named multifollicular appearing ovaries, but I mean, I didn't get a chance to name this syndrome, but that would be more accurate. It's really follicles that are not ovulating regularly, that are just accumulating in the ovary, more or less, for polycystic ovarian syndrome. So for patients with PCOS, believe it or not, if you do egg freezing, you will get probably a higher than expected egg retrieval. You may get way more eggs than your peers, but it can affect fertility because you're not ovulating and releasing that egg on a regular schedule. So planning pregnancy, time in pregnancy may be difficult. There are some things that can help with polycystic ovarian syndrome: is staying active, having a well-balanced diet. Those are some of the few steps: diet and lifestyle. And it's very common. It's actually the most common endocrine disorder in women that affects about 5 to 15% of reproductive age women. And I'm quickly seeing something about adenomyosis. Adenomyosis is technically like endometriosis, what we spoke of prior, but it's when that abnormal uterine lining is found within the muscle of the uterus. So it makes your uterus very big, globular. It does cause painful, heavy periods, and it may affect the implantation of the embryo because it makes a hostile uterine environment. So that's the slight difference between endometriosis and adenomyosis. I kind of relate to them as like cousins because there's still that abnormal, similar uterine lining being found in an abnormal place, but this time it's being found in within the muscle of the uterus. That's just a question I quickly saw on my eye. So there are some behavioral risks, diet and lifestyle. I alluded to this before. So generally, you want overall health when trying to get pregnant. So eating a well-balanced diet, what is good to eat? The bright, colorful foods. If it's bright, colorful naturally, it's probably good to eat. The lean meats, less red meats, more lean meats, fish. Those are also really good. And then exercising at least 3 to 5 times a week for 30 minutes. Some cardio to increase your heart rate is included. Cutting out alcohol, cutting down any sort of drugs, cutting out cigarette smoking. These are all good lifestyle changes that we can actually adapt and we can actually do, not just for polycystic ovarian syndrome, but for anyone trying to get pregnant. Now I'm handing over to Dr. Wood.
Thank you, Dr. Jackman. And so continuing on with the conversation about other behavioral risk factors, as was mentioned before, that mental health and stress can also affect fertility. And I know that it can be really frustrating for people when you hear like you just need to like relax and not stress, because that is really hard to do. But there is evidence to suggest that the stress and the impact of it on our bodies can affect our fertility. And because infertility itself can feel stigmatizing, contributing to anxiety and depression, which begins to sort of this cycle that further exacerbates any impact that our mental health and stress already has on our body. So I'm now going to talk about some of the barriers and how to overcome them. And I think someone had asked like what's behind the statistics of the disparities that we see. So we're going to touch on them. I don't know if we'll get to all of them because it is very complex and multifaceted. But especially as it relates to Black women and the Black experience of fertility. This is nothing new. Health care disparities in minority populations, we've been aware of them for a while. And we are, through panels such as this and education, trying to bring more awareness of the issues so that we can begin to further understand exactly what are the sources of those disparities. And part of, I think, in addition to kind of understanding the disparities is what information is out there. And someone had mentioned before, like, why are some of these tests not routinely built into our annual checkups, which I think is an excellent question. And so increasing our health literacy goes a long way in kind of addressing some of the socioeconomic barriers and reducing some of the disparities that we see. And I mean, and some of it is just things that we as individuals, as building, women, building careers, et cetera, do. And I think that from a mental health perspective, I know that sometimes can also come with stress and other emotions, but we should not, take on sort of the guilt and responsibility of that. But we do have oftentimes delay in family building. We are getting our education, building our careers, just a personal preference of being in a certain place in our life before we begin the family building process. And then also when we start to encounter maybe some challenges or difficulties conceiving or becoming pregnant and delay seeking infertility services. And there are many possible explanations for that, maybe religious beliefs that encourage us to kind of pray on it, think about it, reflect, sort of turning things over to a higher power. There may be also cultural barriers in terms of assessing care and what it means to use or involve medicine in reproductive health. And I think, as was stated earlier in our presentation, just not seeing representation in your care providers, being very isolated and thinking that is not something that affects women of color, Black women specifically. And there's just a lot of misinformation and misconception out there. Our government services, unfortunately, are not designed to help us. In many ways, they reduce fertility, especially in poor minority women. And there are also many of the racial tropes that still exist that depict Black women as being very fertile, highly fertile, and not infertile. And I think being exposed to those, even if we're living it and know that it's not true, being exposed to those kind of contribute to things like delay in seeking services, because we're not thinking that it's related maybe to a medical cause or something else like that. Next slide, please. Thank you. So in addition to the Black women being 2 to 3 more times more likely to experience infertility, we are less likely to seek help. So about 8% of Black women who seek help, there's about 8% of Black women who seek help getting pregnant compared to 15% of white women. And some of the reasons for this is that, access to care is not always convenient. It's not always located in a city near us. We were asking where everyone was dialing in from today. I'm in the Los Angeles area, but I grew up in Georgia, outside of Atlanta, way outside of Atlanta. But anyone that lives in my hometown probably has to drive far to seek services. So access to care is not always convenient, and as has already been mentioned, or affordable for Black women and minorities. And again, this cultural emphasis on privacy and some of the stigma that is still associated with infertility really prevents women from proactively seeking advice, talking about it, and asking, where resources are, getting information to access care. So what are some things that we can do to improve? And hopefully panels like this are a step in that direction. First is addressing the education gap. And at Kindbody, we really try to champion education about the misconceptions and misbeliefs around Black women and infertility. Also addressing the need for diverse providers and increasing the representation. So really addressing the lack of diversity in the fertility space, and think about how we fill those gaps. How do we recruit more people into medicine or into mental health so that we can increase employment for providers in these spaces. We also need to work on destigmatizing and normalizing the conversations around this. So really kind of highlighting and advocating for people of color to bring forward their journeys and their stories. And through all of these, I think we will achieve the goal of empowering and enabling Black and minority individuals to really take control of their reproductive health and be their own advocates for their care. So in terms of, again, access to fertility care, and especially speaking to the financial aspect of it, coverage for infertility services is a function of employers' benefit plan designs. And recently in New York State, there was a mandate that any insurance plans that had more than 100 members are mandated to cover 3 cycles of IVF and cryopreservation for a medically indicated reason, which I think is a huge progress and a step in the right direction. And I think hopefully other states and or other employers are taking note of this. And unfortunately, those small, medium, and self-insured plans are not obligated to provide coverage, but it goes to show just what that would do for someone, right? If you had 3 cycles of IVF covered or cryopreservation covered, what kind of relief and opportunities, and again, access that would provide for people. Other ways to improve access to care, and we are trying to do some of this at Kindbody, is by employer-sponsored programming and working directly with the employers to provide information, access, and benefits to their employees, by putting clinics in places that are accessible. And so if you've ever been fortunate enough to visit one of our clinics, you've probably seen we're out in malls and shopping areas, places where people frequent that are accessible. We really work hard to provide and have a diverse staff at all levels of our staff, so that from the front door to your physician, you'll see someone that looks like you, and really creating and cultivating an environment that makes patients feel seen and welcome and included. So now Deja is going to tell us a little bit about her story.
Hi, everyone. I'm Deja Riley Isadorchek. Thank you so much, Dr. Jackman and Dr. Wood, for all of that amazing information. I actually learned a few new things myself through that. So a little bit about me. I am from New York, well, born in New York, New Rochelle to be exact, and I moved to Virginia Beach when I was very young. So I always say that I am also from Virginia. I was raised in Virginia Beach, came from a very creative family. So I was always in the arts in some capacity. I grew up in the theater and trained classically in ballet, jazz, tap, lyrical, all these varieties of genres in dance. And then I pursued a career in dance, moving out to California when I was about 19 years old. I had the pleasure of dancing for amazing artists such as Beyonce, Lady Gaga, J-Lo, Nicki Minaj, and the list goes on and on. I had an amazing career doing that, and then transitioned about 7 years ago into the fitness industry, which actually ended up bringing me back full circle here to New York. And I joined this organization, this amazing company called Lululemon, and I am now a Lululemon studio trainer. A little bit about my lovely husband. That is him right there. His name is Jimmy. We have been together almost 10 years now. We just met our 9 years on New Year's Eve. So we're going into our 10th year together. We met at a friend's house in Malibu, California. He was a school teacher and still is. I, at the time, was a dancer. We were in our early 20s or mid 20s rather. And we just thought we had all the time in the world to build a family. We were much more interested in traveling and enjoying time with each other. And so the talk of children didn't come until much later. We got married in 2018, and we thought we were just taking all the right steps to family building. And shortly after that, started to have conversations about when we'd like to have children. We definitely wanted to make sure we were financially stable and living in a place that, you know, we both felt grounded in. And so we actually ended up buying our first house during the pandemic in 2020 in North Carolina, and we planned to settle there. And then I got my job up here in New York shortly after we bought the house. And so then we migrated up to New York and have been living here ever since. We decided that once we planted ourselves here in New York, that we wanted to begin our journey of trying to have children and build a family. And we began our journey to parenthood at the top of 2021. We tried naturally for about 6 months, and I was a little bit frustrated because I had heard several times that at the age of 35, you are automatically, qualified as a high-risk pregnancy if you get pregnant at 35 and up. I definitely heard the term geriatric pregnancy, which frightened me. And thank you so much, Dr. Jackman, for reframing that. I'm going to start calling it the advanced maternal age because I'm actually a few weeks away from 35. So we started this journey when I was 33, actively trying for 6 months. And then we were referred to Kindbody by a few friends, and they just said you should, go and do the initial testing and see if there's anything that's preventing you from getting pregnant naturally. And so we did. We tested our AMH, we did the HSG, we did a variety of different tests through Kindbody, and we were ultimately given the green light. They said to keep trying naturally, and in July of 2021, we got pregnant for the first time. Unfortunately, that resulted in a miscarriage in September. I was just shy of 8 weeks, and it was one of the most devastating experiences of my life, one that I am still grieving over and that I think about often, and is part of the reason why I've started to openly share my fertility journey, because I think these conversations are just not had enough. So I'm very honored to be here in this space, sharing my journey with you. We continued to try after the miscarriage, but it took a little while for us to feel confident about trying again. After we tried again naturally for another 6 months, we decided that we might need a little assistance. And so out of convenience, I found a clinic that was a little bit closer to me because my husband and I were living in Brooklyn at the time. And we were actually seeking a Black doctor, but she was unavailable at this particular clinic. And she was like booked up for months. And for me, there was a little sense of urgency there because I was creeping up on 35. I was 34 at the time, or 33 at the time, about to turn 34. And so I really, really wanted to get the process started as soon as possible. We decided to do IUI first with all the options that were presented to us. And we actually had 3 failed IUIs at this clinic. And at the time, I really felt my doctor was rather dismissive, a little insensitive to my experience. And I remembered the experience that I had at Kindbody for my initial testing, where everybody was warm. And I really did like Dr. Hyacinth Brown. Yes, Dr. Nicole Brown. Yes, that's my doctor. I really did love her bedside manner. She was understanding of what I was, going through. She answered all my questions thoroughly. And ultimately, I didn't have to explain a huge part of my experience to her. So I really valued that. And I told my husband, like, no matter how far it's going to be for us to travel for appointments, I'd rather be in comfortable care than be, with a doctor that's conveniently close to us or within proximity. So I decided to go back to Kindbody. I shared my past experience with the IUI failures and my experience with that particular doctor with Dr. Brown. And after hearing my experience, she actually wanted to do a saline sonogram. Dr. Jackman talked about that a little bit earlier. After she looked into my uterus, she found 2 polyps, and she wanted to do a hysteroscopy, remove the polyps, and then do a small DNC. And so she did that for me maybe less than a week later. I was under anesthetics for that. It was covered by my insurance, thankfully. And she removed the 2 polyps. And in our debrief, she told me that they were blocking my left fallopian tube. So I was actually really relieved to hear that information, because I thought maybe there's a possibility that that was causing the either pregnancy loss or the failures in procedures. And so I was feeling hopeful again. And we decided to go ahead and do another IUI, but this time with Kindbody. I had a much better experience, and I felt so much more comfortable with this team. Unfortunately, that IUI did also fail. And Dr. Brown basically sat with us, and she explained that she could continue to do IUIs, but her recommendation would be to go into IVF. She let us sit with it for a while. My husband and I talked about it, and we decided that we were going to embark on our journey of IVF. And now this takes us all the way to this past December 2022. We started our IVF journey. For me, I'm a very active person. So the hardest thing for me was to not be doing high intensity dynamic exercises during this time. I ended up really feeling a lot of stress, and like it was mentally heavy on me. But we did have a little bit of success here with being able to bank 1 embryo. So we started out during the retrieval process. They were able to retrieve 13 eggs. That number then dwindled down to 7 mature eggs, 5 of which were showing normal signs of fertilization. And then it dwindled down to 1 embryo actually being fertilized. And we sent it off for genetic testing. And that embryo came back with all full 46 chromosomes, no abnormalities. And we were very happy to hear that. That male embryo is now frozen and waiting for us for when we want to do a transfer. Thank you. And so we're in the midst of that journey. We have not done a transfer yet. Dr. Brown's next recommendation was to do another retrieval, since we do want to have multiple kids. And I just felt like my body needed to get back to some movement, and I wanted to be in a better mental space before I decided to do another retrieval. And so we are taking a break right now and pouring into our marriage and enjoying each other, and making space for the family that will be in our future.
Thank you so much, Deja. I mean, what a journey. You can see all the love in the chat here. Everybody is with you, and we know you're going to have that baby. I have no doubt in my mind. Look at everyone in the chat. Everyone's with you. Thank you, everyone.
Okay. Feel the love.
Yeah, definitely feel the love. And thank you, Dr. Wood and Dr. Jackman. So as we know, the path to parenthood isn't always linear. Like Deja just said, it's always a journey. There's always ups and downs. Very few times we get a perfect, straightforward journey. And so please keep in mind that it will be different for everybody, but you'll get there and you will be successful. And we're here to help you. And with that being said, of course, you have options to become a parent one day, to become a parent today, egg freezing, embryo freezing, fertility treatment. We have all kinds of different ways to help you build your family. So visit kindbody.com, book an appointment, book a consult, see what's right for you. We're here for you. And we're so excited to have you all here today. And like I said, the first step is really just to do that initial consultation, to speak to one of our providers and to go through your medical history, take some tests, see where you're at, and then they can look at what possibly you could do next and what treatment might be right for you.